Good morning, everyone, and welcome from all around the world to Structural Heart live cases broadcasting from the Cardiac Cath Lab from Mount Sinai Hospital in New York City. I'm Dr. Philippe Généreux from Morristown Medical Center in New Jersey, and I will be your host and moderator today. This video, the video of this broadcast will be available on the website later today. The last broadcast from May 8 and all the previous structural heart cases are also available now on www.ccclivecases.org. We'd love to hear from you, so please email us with all the questions to info@ccclivecases.org. We have a great case today, and please let me take you to the Cath Lab of Mount Sinai Hospital for the live case, where Dr. Kini, Sharma, Khan, Tang, and Perk will present this interesting case for you.
All right, Philip, thank you to be our moderator, and welcome you, and we welcome all our audience of our structural heart live cases. And this is, we actually do tower most of the time, but there has been a great demand for the mitral cases. We did TMVR in February, and now the mitral clip. Last clip we did was in August, and clearly with the new addition of redesigned or additional improvement and the new availability of the new clip, which we'll talk briefly. It seems to be appropriate, knowing that the mitral clip is, I'm sure it will be on rise, and hopefully will the trial data which will come for the functional MR, which will be released later in the TCT, will make it a big difference. So this case is, and I welcome all of the team. Left side is Dr. Kini, then Dr. Tang, and right is Dr. Asad Khan, and then our international fellow Muhammad, and rest of our staff here. So what we do usually is just present the case quickly, knowing that this is a lot of technical will be required in this particular case in terms of hands-on and deployment of the procedure. So we keep it lit to just a brief presentation of the case, then the whole discussion about to perform the case, which will be done by Dr. Kini with an assistant by all of us. And in the end, the time remains. I always present some didactic latest data, and data will be on the TVT mitral clip registry and the importance of the residual gradient, mitral valve gradient post-procedure, impact on the subsequent outcome. So with that note, we can start our slide quickly. Next. These are our disclosures. Next. So this is a 87-year-old. This is our episode number 24. Patient worsening dyspnea for last 6 months, has known MR in the past, also has ischemic cardiomyopathy with EF around 30 to 35%, has a stent, and which has been patent now, has 2 times intervention of that LED stent. And the whole issue is that patient continues to have now more progressive heart failure, which led to the echocardiogram showing the dilated LV and global hypokinesis with the severe mitral regurgitation, and on the TEE, partial prolapse of the posterior leaflet with severe centrally directed MR involving the A2 and P2 segment. And of course, you'll have a chance to see live by our echocardiographer of the director of structural echo, Dr. Gila Park. Next. So this is the pictures which we had before. So good echo, guys, you guys can comment. Yeah, okay, good. Next. So transesophageal and all shown. Next. And this is basically put together, STS risk mortality of 4.14 and Euroscore mortality of 13.1. Patient was evaluated by heart team like at your center everywhere. That's mandated by our CMS and documented. And patient was determined to be prohibitive risk for surgical MVR due to age, comorbidities, and frailty. So today, referred for S2H mitral valve repair with a mitral clip by transfemoral venous access and transseptal puncture. And they actually don't even have any arterial line except the anesthesia. Dr. Stone is there. They just keep a line, but no arterial puncture in the groin. I mean, that's a great thing. Next. So this will be the mitral clip device, which is, we have shown it before also. Next. The more important is this is addition, and I'll ask Anu to comment on, and because they did the first case already yesterday with this new clip, which is XTR compared to old NTR. Anu?
Yeah, so if you see the old system, which is also still available, NTR, essentially if you see the length of the clip itself is, the NTR was like 6 millimeter, and now the XTR is 9 millimeter. So also what has happened is with the DC handle, the torque is 1:1, and more important is once you open it, you don't need to relock the clip again. So very easy to use. And what the term they keep using is that you are able to customize your mitral valve therapy to every patient. In the past, based on the annular dilatation, the annular size, and if the leaflet, there are many cases where we have not been able to grasp in what we are saying is not just degeneration, but many of them are combined, degeneration plus functional. And there have been cases where we know we were not been able to grasp, but with this newer XT, we will be able to grasp all these cases where you have annular dilatation. But more important is, I think it's way much easier to use, and grasping will be faster. You'll see as we do the case.
And the other question is, will it decrease the overall incidence of second clip? Gilbert, what do you think? Knowing that in the studies have been about 20% second clip and third clip in about 4-5% of cases.
That's an excellent point, Dr. Sharma. I think it depends on the pathology. I think the advantage of having both XTL and NTL, as Dr. Kinney says, you can customize the need for either one clip or two clips. So depends on the breadth of the jet, the baseline gradient. The key with the mitral repairs we know is surface coaptation, leaflet coaptation. The fact that we have a newer, longer clip increases the leaflet coaptation, can probably avoid the need for a second clip for some cases, but certainly improve the outcomes of mitral repair. I think that's the most important message.
And the other things also could be in somebody like this patient who has very dilated ventricle. So by putting the first clip as the XTR, will bring it so that your second clip will be much easier.
Correct. That's
Maybe.
absolutely right. You increase the surface coaptation, and will be interesting to see in future study whether there's even an annular plasty effect. There's already some discussion of that already.
Okay. Next, I think this is just the individual the device which you'll talk about practical.
Yeah.
Next. So these are the various knobs and handle. Keep going. Next.
So you see that essentially, I think three things you need to know. One is the system will include that steerable guide catheter. That is very important, which is the first thing that we are going to introduce, and after that will be the clip delivery system. So everybody uses the term what is called as CDS. That is what, after that we just talk about what's called as a DC handle. When we use the term DC handle is the last part. You see that it is clip delivery handle, but the term we call it as a DC handle. So this terminology will be using when we are doing the case. And you see the stabilizer that's holding the entire system.
Okay. Good. I
Next.
think we're ready to start.
Ready
Yeah,
to start.
yeah,
Okay,
yeah.
we can,
Yeah.
Gila, if you can show us the echo,
Yeah.
and
Good.
go over the echo now. Can we
And-
show the live
and-
echo?
And this is the live echo, yeah.
Yeah, so first thing that we see is that the patient dilated cardiomyopathy is moderately
Loud.
reduced, about 5 to 40%. And you can already appreciate that the valve leaflets are restricted in, and we see it a little bit better here. There's pretty significant MR. It's a very from the entire coaptation of the A2P2. And we can look more closely at the valve. This is an important view. This is the intercommissural view, where we can see the one A2P3 scallops. Define exactly where the MR is coming from. And again, looking at this, we can see that this is from the entire A2P2 coaptation. We can see that also on the 3D image. We see a very wide jet right smack in the center of the mitral valve. This is an important view for us to look at when we're doing the clip. This is a commissural view on the left side, and an X-plane view. This is a perpendicular view to that, looking at the LVOT view, where we see the exactly the A2P2, and we can see exactly where we want to place our clip or two clips. When we look at it on 3D, this is important. This will become important later when we orient the clip arm. Also, the 3D in order to make sure that
Did
we
they
have
give that
the
in
adequate
2000?
valve area
Yes, yes.
before starting.
But now
Look at
it's
the
long
valve
time
area,
ago,
which
no?
is 4.4 in this case,
How much does he weigh?
with a baseline mean gradient of 1.
Mark, how much does he weigh?
Okay.
So we need to make sure
Give one
mitral
down.
appendage
Give one down.
the patient doesn't have,
Give one more down.
and we're ready for transseptal.
One more 1,000 happen.
All right, so we are all ready to start. And now based on this, let's ask Asad also, is our young budding structural interventionalist. That
Groin
what-
access means the
Yeah.
vein, figure of 8,
Yeah.
and the pre-close. Tell us, Asad.
So different strategies are used for pre-closing the vein and stuff. We have adopted 2 pre-close strategy, and also we do a figure of 8 suture just as a precautionary
You want
measure.
to just show it,
Yeah.
camera?
Okay, now.
Camera can
Can
go
we
on the
see it?
groin.
Yeah.
So we have done 2 pre-closes here, and also we have put a figure of 8 suture, which will put subcutaneous pressure in the end. You can do this the same thing with just 1 pre-close as well, but just to be on the safe side and avoid any potential groin complications, we have adopted the strategy of putting 2 pre-closes and also a figure of 8.
Yeah, with this strategy, it's really fail safe. We have zero vascular complication in all our MitraClip cases.
Yeah, we actually had one complication on the mitral clip. Last time we did 52, and that was from arterial side.
Four
Right
French.
four French artery.
Yeah.
That's when we stopped taking the arterial
Arterial
access.
access.
Yeah.
There's no arterial puncture here.
Yeah, with echocardiographic guidance, really not necessary to have arterial access in these patients.
Now, Philip, how are you using? Are you using this figure of 8? I know
What
people
size
are
is
using
this?
pre-close,
What we
but
can
what are you
use?
using at your
8.5
center?
Yes, so we use the same as you. So we use
This
one
is
pre-close,
not the page.
one per-close, and then one figure of 8.
Okay.
And
Good.
one thing to mention is we always use ultrasound-guided puncture
SL1.
to ensure to reduce the complications. So, but similar technique, yeah.
Okay, good.
And as soon as we get access, we give a little bit of heparin, 3 or
that's
4,000.
That's an interesting point. In the beginning, we never did it, but what you need to do is, while you're doing transseptal, since one of the key aspect of clip is getting the right transseptal. For that, you'll take time and make sure you're at the right spot. So it can go anywhere 5 minutes to 15, 20 minutes. So you have to give heparin, 15 to 2,000 units of heparin, so there's no clot formation at the level of the septum, and you have the sheath there. Now,
Okay.
what we used is a SL1 sheath, which is already inside, and we have the Baylis needle. Are you showing it? Right? Good. It's all flushed. Everything is good. Yeah.
So we connect the Baylis needle to the hemodynamic monitor, so we make sure once we get access, we in the left atrial pressure can be directly measured, so we're in the right place.
And that's
So
the
the-
measurement is the research tool now to see what is your residual atrial gradient besides just the degree of mitral regurgitation correlating the outcomes at the future.
So
Okay.
now you can see my handle here, right? Keep showing my hand. Are you able to see that? You can see the tip coming out. On the fluoro, are you able to see the tip
Yep,
of
yep,
the?
yep.
Yeah, it's
Yes?
beautiful.
Good. So I'm at 5 o'clock position, between 5 to 6, so keep coming down. So on the echo, we are showing the bicable view.
So I think instead of hemodynamics, show the echo.
Yes.
We'll tell you when to go to hemodynamic. Just show the continuous echo. Beautiful.
So I'm,
No,
I'm
no
keep-
other way. The lower screen, change it to echo.
I think that's very important to have this picture because you can
Yeah.
appreciate the anterior and posterior movement of the needle.
Yes, beautiful.
Perfect.
Good. Yeah.
So you can see so I'm coming down on the bicable view. Can you see me? No. So the tip is closer. You see that now? Yes. You can see me. Yes. Coming down. So keep the same view. No more change in the echo view. So
Is it-
keep till you come to the center of the fossa.
It's a very thick septum with a small fossa.
Yes.
Yeah,
So you may see a small jump now.
yep.
You feel it. Yeah. Nice.
Fluoro, please.
So we predicted the jump. Now you see the tenting. At this time, you will go to short axis. And I'm going to go posterior. Can you see my hand movement? So I'm rotating little posterior.
It's a little clockwise movement.
Yes.
Yep.
Nice clockwise movement will
Good,
take me
good.
posterior. Beautiful view there. We are stopping. So it's nice posterior, and we can give us the height measurement, Gila.
Yep.
So this is a beautiful 4-chamber view there. So what you'll do right now, you'll take the annulus of where the clip is. You see that? The tenting, nice tenting you still see. Don't move the, yeah. From there, yes, all the way down.
4.1.
4.1.
And how much it should be?
Yeah, about 4 and above.
Oh.
Okay,
So more important is the height, and other thing is posterior.
good.
I think we zap here. Everybody agrees?
I think it's a beautiful demonstration how important this is, and I think with 4.1, especially with this new XTR, it's perfect. The longer arm will allow you to have a beautiful result. Yeah.
Okay, you see that? You need to see the little bubbles. Nice. Okay, so we're going in. So see my movements, please. Hand movements. So I'm advancing the whole system. Little bit of the whole system in. And then,
You lost the tracing of the left atrium right now.
no, we'll come back. We
Okay.
got it.
Advance the needle. Yeah.
I did.
Okay, when.
Yep.
Okay, good.
Went through.
So it's very important, as Dr. Kinney pointed out, that you maintain the needle because it provides the stiffness for the transseptal. Because often in the elastic septum, if you don't, the dilator may not be enough, and you end up actually not going through. And that's one of
So
the
first
tricks
thing
that
you
we
do is give the full heparin. You want
Yeah.
to do another measurement?
Yeah.
It's running now.
Yeah.
Okay, good.
You give 6.
Now other
no,
thing is full measurement.
give a
Gila, you
total
want
of
another
6,000.
height, or we are good? We don't
Total
need.
of
And just
6,000.
connect to
Sure.
the pressure.
Total.
once
Yeah, I'm
now
giving
that's
a
fine.
pressure.
Yeah.
You can show now you can show the pressure.
Okay, go to show the pressure at 50 scale.
At 200. Change it to 50 scale.
Left atrium to
Total
50
6.
scale.
And then to ACT.
It's running.
Okay. Over
See, the
250.
one good thing, I don't know, Philip, what system you use about this bail is it is atraumatic. See the way we did it, that one, because the radiopac tip, the echo, you are able to see where how your transseptal catheter and needle
Absolutely.
movement,
Yeah, we
and
do the
once
same.
you are at the right spot, you don't have to do anything. It's atraumatic, and when you think it is right, you just do your zapping, and you're able to get the transseptal. Is our height is good, right, Gila?
Yep.
Yeah.
Good.
Mm.
That's it. So now once we are done that, the wire we use with the confida wire, which the same wire we use for the tower. So it already comes the heparin is in.
Yes.
Okay. Heparin has to be in, and your ACT above
Are you doing
50 before we even think of moving with the
Mark?
guide.
ACT
Yes.
276.
So you see that?
No, 276.
Essentially,
That
it should
was
be in
after
the left
6,000?
atrium. The initial teaching
It was
used to
more
be that the wire has to be in the pulmonary vein, but at this time we don't focus on that. As long as you're in the left atrium, and in this case, we know that the left atrium is large. Now we'll take out this sheet. Yes.
We really love to use the confida wire as well because it's very atraumatic and
Yeah.
safe, especially when you aim for the pulmonary vein. This is right now our wire of choice. We used to use the M-Plats, but we switched
Yes.
completely to this wire.
Nice. So it comes out.
Good.
Now get us the steerable guide. Now very important, we have to dilate first, yeah. So the guide is a 22 French, so we are going with a 14 French dilator. So dilate the vein as well as the tissue in the groin, making sure you're right.
For injection wire.
Guide is okay there, yeah, wire.
This is 18. Yeah, this is dilated track.
Do you need a
Right.
bigger,
No, this is good.
no, the skin nick.
No, it's good. Go, go.
Let me look.
Okay, now we have our steerable guide. Very important, what you need to do with the steerable guide is the knob movements, and other thing is you need to activate. Take a wet gauze. This whole thing needs to be activated so it is very slippery. So the knob has to be neutral now, not positive, make it negative, negative. Go negative.
think that's very important to
So
it's
put more
make the
fluid.
insertion very easier when you take all the plus out
Yeah.
and in neutral
Can we zoom in
position.
at the insertion? So you can see the advantage of using a figure 8 or mattress suture here is that I don't need to put my hand on the groin. You know, you keep the entire view in place, and you just pull this up to be able to tamponade the area to hold pressure.
Yes. So same thing, one person is holding the wire. Give me the dry gauze. Now it is too slippery.
It's going.
Okay, good. Always there is some resistance, even if you have dilated the groin. Nice smooth movement. Keep going, keep going. Oh, wire.
Pull the wire a little. Yeah. Keep the
Wire.
wire that position.
ACT is 276.
Yeah, we gave 1,000 more already.
Okay, now when you are here, go plus.
Go back to neutral.
That's good.
So once in the
Neutral.
left atrium, yeah.
Now the thing is, Gila, we are coming
Yep.
in. Can you
Yep.
see us?
Yep.
Did we cross?
Um,
I think it's a thick septum.
not sure that the guide is.
I think you're
Okay. Wires.
I think you're tenting, but you're not crossed yet. Yeah.
Yeah.
I think this is a little thick septum.
Maybe you have to do some rotation.
Good.
of
Yep.
the- yeah.
Okay,
Yes,
now
sir.
it's through.
That's an interesting point which Philip mentioned is the same, that if it does not go,
Mhm.
what you'd go, do you take your handle here,
Mhm.
just gentle rotation, not aggressive, just gentle rotation.
Yep.
If it does not go, then you take the whole thing back, and the technique that we showed in the past, that you may have to go and balloon dilate there before you get in. Yes. Yeah. Guide is too deep in, so pulling
Yep.
back a little bit. Yes. So now next step is that you bring your stabilizer.
Mhm.
Stabilizer is right here. And the way they always tell you is that when you are placing the stabilizer, this should be facing your eye. Good. And then you put the screw, so your steerable guide is nice and tight. One thing that we do is that we have a three-way stopcock here. We'll connect it to the pressure. So we will have a LA pressure tracing
just to take the
all the time.
Forward, yeah.
So first thing you do is the dilator comes out. Just the dilator comes out. The wire still there. And now you take out the wire also. Are you showing the fluoro? Now the wire came out. This is a very important point. So there is other thing is right here. Wait 1 second. Let them focus here as you're taking it out. You cannot have air being sucked in. So what happens is everything is coming out. See that?
You
So
still
keep
have
tapping,
a lot of
tapping,
vital cords.
tapping, and withdrawing. Good. Now you flush. So there will be no air bubble or anything going in. Give me a bigger flush. Gila, you were saying something.
You have a lot of guide across,
Yeah.
2.5
Okay, we will
centimeters.
pull back. So no blood, everything is clean. How is it connected? Now you can see the LA pressure tracing. So this will be a continuous LA pressure tracing that will happen as we are doing the procedure. You see it?
Need to
Yep.
clean it up a little bit. Maybe pull back
Okay,
the guide
wait.
a little bit to pivot.
I think that's a beautiful tracing. Before, we also do this in our case. Also, one thing we do before is to have the pulmonary vein flow measure to see if we change something during the case. Is that something you do routinely in your cases?
We routinely don't do that,
Mhm.
right? On
Echo,
echo,
on
on
echo,
echo
on
she does
echo.
it, yeah.
On echo.
On echo, the PV, the pulmonary vein flow, it's something,
Yeah.
some value sometime.
Yeah, we do it on echo because after you place the first clip, your color flow jet, the color jet can actually get distorted.
Yeah.
So you can falsely think it's actually getting worse.
Now, is
But
a guide
pulmonary flow is-
enough, or do we have to pull back? Guide, good, enough. So now introduction of the
So one thing we notice also is that with the transseptal sheath versus the actual guide, the pressure, there's sometimes a bit difference. The V wave actually is higher with the guide because the larger opening. So So we use this as a new baseline so that we can compare before and afterwards.
So the steerable guide, you know, movement is that same. If you go, this is anterior, and if you go counterclock is posterior. Just remember that, okay? Anterior, posterior, this movement.
Yeah.
Now will be introduction of the clip. So same, you have one per, will be fluid, and as you enter here, okay, good. And now your blue to blue connection has to be good. You see, can you? Okay, cannot see that.
So what we've done also, you can see on fluoro, we simulate the guide position where we think that we are in safely have enough across. So we have used as a reference point. So we can also use fluoro at the same time if echo is not able to get the image to be able to see how much guide we have in place. So we can
Okay, now
translate.
can you focus, come this side?
Yeah.
Here,
So now
my
we
hand.
Yeah.
How we go in, and that show the next important part is the straddle as it comes out.
Yeah.
Mhm.
So now you see there the clip is coming out. So I'm advancing from with the left hand, and with the right hand I'm going in. You see that? Everything is going in. Nice. So you
This
come
is
out, the
this
clip
is
coming
a
out.
very good demonstration of a well-controlled advancement.
Yeah.
One end can stop the device at any time.
Now I have straddled it, and I'll explain what straddling is. It's good, straddle.
Perfect.
So essentially what happened is the clip delivery system that just went in has two radio opaque ring, and then your steerable guide catheter at the tip has another ring. Got that? So the two rings of the clip delivery system, the steerable guide catheter ring has to be at the center of the two rings which are in the clip delivery system. So you got this? CDS has two rings, and then you have a steerable guide.
Yeah.
The center of the guide, can we go Sine?
Yeah.
You see it now? There are two rings on either side of the ring of the guide. So this is called straddle. So what does straddle do? That your clip delivery system, amount of the length of the clip delivery system and the height is good enough so that now you will be able to move the clip delivery system to get the right trajectory to enter the mitral valve. So next we will do is the movement which should be posterior and then will be medial. Why posterior? Is essentially to say that the posterior leaflet, which forms about 2/3 of the annular attachment of the whole mitral valve, the line of coaptation, which we call the smiley face on the echo, is posterior. So that is why you go medial, because that is how the mitral valve is facing, and then you go posterior. That's the movement we are going to do now. So you see here
At this
medial.
point is,
So
So
the
on the
medial
echo-
knob is
yeah.
here.
Mhm.
I'm going to go M.
Yeah. So I pull back the
You
system
start
as
seeing
well
the
to
echo.
clear the
See, I'm,
committed ridge.
You're good.
and then I'm going a little posterior.
You want to show fluoro in this one?
Yeah.
you just clear the
Other
Coumadin
thing
ridge.
that we have to be very careful is
Mm.
avoiding the Coumadin ridge, right? So normally when we are doing this movement, suppose we are too lateral, we could be in the left atrial appendage. So what is Coumadin ridge? The edge of the left atrial appendage and the atrial pulmonary vein is the Coumadin ridge. So that's likely the clip may get stuck in there. So you have to make sure you are not close to that.
You want to use fluoro to show.
Coming down,
Yeah.
right? So I'm
So you can
going
see
to
on fluoro that you can do the AM, and you can see the clip on the echo as well simultaneously. It's people say it's an echo-driven procedure, but actually you need to integrate fluoro and echo at the same time to see,
I'm going in a straddle a little bit more, right?
and it makes
Yeah.
the
You have to
procedure
constantly
much
adjust
more
it, yeah.
efficient than just relying on one modality alone.
Okay,
have to
so now I'm good at M. Do you want more?
We have to constantly retract the DC handle.
More M?
Fluoro.
No, for the
Yeah.
Mm.
At this point, we also
So
like.
why we were checking on fluoro is the same, that it has to make a 90-degree angle on the fluoro. That's the time you know that I think you have appropriate amount of M.
Mhm.
We like to use the 3D also view to help to guide the posterior anterior.
All right, Gila,
At
let's
this
do
point.
the 3D.
Not yet, not yet.
yet.
We have to not yet, because you got to be the line right
Above the
cooptation
valve.
right above the valve. We are not above the valve yet.
Go ahead.
So the question
very
is,
lateral.
do I bring medial, pull back the right? Good.
Up, yeah.
Yeah, pull back slightly.
Yeah. Yeah. Let's bring the clip closer to the valve. I think you can
Okay. I'll go
Okay.
closer so she'll
So
see
the
it.
valve, we are
Follow.
advancing, moving with the DC handle. We are going closer now. You see that?
clip fluoro.
Why fluoro?
No, you need to see the valve.
Yeah.
Good, stop.
So we
You
checked on the
above
floor
valve.
also. So we are right above the valve. I don't like the trajectory,
Okay.
right?
It will dive more medial.
Yeah, we can do a little plus as well.
Yeah. Yeah.
Yeah.
Little
Plus.
a bit more M.
How did you have? They did it or no?
There. Yeah, pull back.
So I'm bringing a little bit medial. So to do medial lateral, you move the stabilizer. So I'm bringing the stabilizer back, so we are more medial. Okay, see that? Now we are coming a little closer. Okay. Gila, put some color so we know we are on the right part. Yeah, see? This is very important,
Yeah.
that this is exactly where the jet is.
Okay, good.
Let's finish this.
So
case.
now do we
Damn
open?
days.
Yes.
Goodness.
So very important opening part. Are you showing here? So what you do is you take the grippers. You see this? These are the grippers. You just pull back till you see the nice blue ring. Close it.
Good.
Same thing. This will be the clip where you pull back.
Unlocking.
Yeah, unlocking so that you can see the blue line, and then you move it so that it's unlocked now.
Now
Yeah.
It's good.
open.
And you can leave it
Open
unlocked.
now.
You're at the diagonal.
So you will have to see under fluoro that when I open, the clip is nice. You see that? That's good.
60. Yeah. Okay.
Go to
Guy,
60.
that guy.
No more. Now,
More.
since we showed, you see that the clip is longer, we will enter the LV at 60-degree only.
Mhm.
Otherwise, it may
That's stuck.
get stuck and
One more.
Now we do
get to the
3D.
wall.
We don't
You
push
need
it
to
back.
rotate the
Lock
clip.
it. That's what I'm saying. We no longer
Yeah.
have 10
So with the old system, what we used to do is once you open, we had to lock it. So with the new
Keep showing him
system,
doing wrong.
don't have to lock it. We just keep it unlocked. That's it.
So 3D.
Now we can go 3D to see exactly how the line of cooptation is. So it has to be perpendicular. The clip has to be perpendicular to the line of cooptation, and we see the smiley face.
You need to rotate clockwise.
It is not, right?
Yeah,
No, you're not.
Yeah.
So
Clockwise
which means
rotation.
Lock it.
you take your DC handle, you remove your screw here, and then you move backward, forward, which is a clockwise. Very small movement. Small, gentle movements like that. Like your translation, they say is much easier here. It
Yeah.
used to be 1 to 3 for that. Old system 1 to 1 here. So I'm doing like the flossing movement. See there? You want me to move more?
Let's just
It's a lot. Why is it not? Okay, now it's good.
Yeah, let's use fluoro. Show them the fluoro as well.
I think this little movement of back and forth
Yeah.
is very important
Yeah.
to translate the tension.
So
and,
you can see on fluoro as
yeah.
well in matching an echo. That looks pretty good.
Good. What do you think?
And
Is it
that's
like
Much better.
great.
line of
Let's
cooptation?
take the parallax.
Oh, yeah.
What are we? 12 and 6 or 12 and 5?
Okay, perfect.
Okay, Gilbert, just explain what we did.
So what we did
did
actually
audio.
is that you see that on 3D echo, the clip is now perpendicular to the cooptation line that Dr. Kinney mentioned. So we actually rotate the fluoro to take the parallax out of the clip as well. So when we enter the LV, we can see whether it spins so that we can align the trajectory, because this is supposed to be optimal trajectory with a position orientation of the clip relative to the mitral valve. So this is an additional tool that we use that's been actually very helpful to make sure that we don't have any minute rotation of the clip when we grasp.
Gilbert, I think maybe
Yes.
more clockwise.
A little bit more, what?
Maybe a little more clockwise rotation. Look at
Okay.
it.
A little more clock, a little bit more clock.
No
I'll
more
show you
clock.
on the
A little bit
2D.
more.
More clock.
I
Gila, you're
think-
saying
yeah.
clock more?
I think a little bit more.
What they're trying to achieve is really a 12-6 position.
Yeah,
Yeah, 12
almost.
6. But okay, now I think we're good, no? 12
Yeah.
6.
Let's see.
Yeah.
Hold on.
Yeah, I think that's better.
Touch more. No?
Looking good there.
I think we're good now.
I think that's good.
Okay,
That's good.
so other thing
Yeah.
is, once I've done the DC handle movement, you see this black knob that I'm showing, can you see that? Always tighten it, otherwise it will go back to your original position. So tighten it. So we are looking good there.
Mhm.
And on the fluoro, what Gilbert was mentioning, if you see there is no parallax. Essentially your clip, is one line. You
Yes.
don't see the two arms of the clip moving on either way. So it's nice one line, so we know everything is looking good.
Any
Move to
plus?
the LV now.
The trajectory. The trajectory is
Yeah.
At this point, I may ask a question about
Yes.
your strategy. So if you are thinking to clip, are you thinking to go in the middle first and see how the jet will behave, or to go in the more lateral part of the jet where is the most severe jet and to put another? So where do you think you're going to land your first
Middle.
clip?
Middle,
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 and
little bit
then
medium,
we'll
slightly
go.
medium.
The lateral one
Yeah,
next, if
lateral
if
later.
we need.
Yeah.
So you're going to go in the middle and then
Yes.
see how that's good.
How it looks.
That's
Lateral
great.
is easier.
So now we are saying we are not happy with the trajectory, right?
Echo.
Yeah, on the echo trajectory doesn't look good. What do you think, Gila?
Put everything on this one.
You're probably gonna go. You're right now. You're right in the center.
Yes.
Yeah, yeah.
So you can try.
Should we just go in and check?
Plus.
Okay, we are going a little plus.
Give us a 3.515. 3.515.
So clip is too closer, so we are pulling back the clip little bit up. See that? That's good. And again, tighten your black knob. And then we are going a little plus.
And then a bit interior.
You moved a lot median.
Yeah.
Always with plus, you have to go interior.
Or
So when you give it a little bit of a plus, you're getting a little bit posterior,
So you
Oh.
always go interior after that. That's what you do.
and you can
Did-
correct
I
for the
did
interior
interior, yeah.
position.
Yeah.
Yeah.
And you go medial, so you reduce the M.
I like it more. This
So
is
better? I took the a little bit M off.
Yeah.
So in the bicom, we
Yeah,
Huh?
a little more plus.
Plus and anterior. That's what we are doing. Right?
Mm-hmm.
we are going medial.
Yeah,
And
good.
And then pull back the clip. a
Push in
little.
the thing a bit, and then close to different.
Then let's come out. I cannot do any more pullback. No?
No, you can.
No, but then we can understraddle a bit if we have that.
Okay, good. We pull the guide out.
Yeah,
Yeah.
that's good.
You have
We
room.
have room.
Yeah.
Yeah, then pushing the whole delivery. So we are on the middle.
I'm pushing in. Good. Central now?
Yep.
Okay, Gila, we are good?
Yep.
Do we enter the LV?
Yes.
Okay, I'm going in now. So same DC handle, you release the knob and I'll go in slowly.
Just so then it's just no, in case you have to go and when you go in. you
Okay,
have to go a little
slowly.
more,
So you see with my left hand, the right hand is on the guide, and with the left hand I'm going in. Go in slowly.
Nice.
Yeah. Perfect. Stop there.
Good? It's already caught. Okay, I'll leave it there.
Just
And then
it's
same,
just
I
this for
will
me.
tighten the knob, black knob.
It's okay, no?
Just take it a little bit more. Yeah.
We are 60 degree. You want to open it a little
That's
bit
fine.
more?
Yeah,
Huh?
now we have to go to open at 120 for
Yeah.
grasping, right?
So I'm going to open, okay?
It's always locked. It will
Yeah,
be
it's locked.
Yeah.
Opening it.
Yeah.
Okay.
Yeah,
Okay.
in 3D.
3D Gila
You can
Okay.
open to 120.
It's falling right on us already. This would be
is 120. We open.
Is this
So
good, Joanne, for 120, or you want more? A little bit, open more. Open a little bit more.
So one great thing about this XT system, like you see here, is since the clip is larger, 3 millimeter longer. As soon as we go in, look at the leaflets are already
Yeah.
right
Yeah.
compared to the old system where
Yeah.
we have to like
Mhm.
How's
do
the
a lot of
how's the
movements.
orientation?
You need to rotate clockwise just a tiny
Yes.
bit.
Clock little bit.
Clock, yep.
Okay, so I'm going to release the knob again and little movements. So every movement has to be small and gentle movements. Yeah, translate like that. Like flossing, dental flossing. See that?
Good. Good. That's
Good.
better. That's better.
That's
now.
nice.
Better.
Enough,
No,
right?
Enough. Yeah. Yeah. No,
Yep.
no,
Good.
almost.
Huh? More?
No, she's saying ask Philip.
You want
Philip, what do you think? We're good?
I think you're very good.
Okay.
And it's very important to be gentle when you do this under the valve to
Yes.
not cut into chordae and muscle, but you did
I like this.
perfectly.
Ready to go.
Yes.
Ready to go.
Very nice.
Okay.
Very good.
Ready to grasp? Everybody agree?
Yeah, we come up.
Yes.
Ye-
Nice.
Yep.
Okay.
Yeah.
Okay,
And
so
pulling back.
now these are the views that we need to be using when we are grasping.
Bicom view.
Bicom view.
And we explain the bicom view.
So same I am going to release. So what you are doing is, if you can see my hand movements, my left hand is on the DC handle, right hand is on the DC handle, and the left is on the guide catheter. So guide catheter will be going posterior, anterior as you need it, and I'm pulling back. And the movement has to be so small that barely you see it. And Asad, you have to be ready to drop the
Yeah.
grippers.
Yeah. Both.
So you have to go a little posterior.
We put one stand,
we are
we
both.
go home by
Yeah.
evening.
Go bit and
Came out first.
I talk a little bit anterior
Yeah,
now.
one stand.
That's good.
Mm-hmm. Yeah. Okay, I'm dropping. now,
Okay,
Dr.
we're
Park.
dropping now.
We're
Okay.
Gila.
Ready, yeah, good,
So
go.
she-
You have
Okay.
to tell the
Coming down now.
yeah, so that they can record it. You see the grippers going down.
Mhm.
Good. And now we are locking. You close it. Good.
Here, okay.
Okay, now you have to assess for the
Do you undo the tension?
undo the tension. What we are doing is, I'm going to go in a little bit. Your DC handle go in a little bit,
And then
Nice.
And then secure.
and then secure it and hold it. So you have to look for the leaflet attachment. That's the term used. So that now Gila will check, did we get enough of the leaflet inside the clip?
Yeah. And also you can see on fluoro as well, the clip has not rotated.
Show
any-
that, show the fluoro.
Yeah,
So
so
they
you can
understand.
see-
You see that?
Remember when we started, we seen an image to make sure the clip is aligned. You can see the two arms are overlapping each other. You can see now at the grasping, it stays the same. That means the clip has not torqued. This is a much more important device to make sure that's the case, because the longer clip arm, if it torques and once you release the clip, you can actually create more MR.
Oh, yeah.
So we have used echo and fluoral.
And very important, show the hemodynamics. We had V waves up to 45, 50, and now look at it, 30. Show the hemodynamics, please.
And that's
Oh, it's
before
showing.
the clips were even
Yeah,
is
we
even
haven't
closed.
completely closed.
Exactly.
Okay, show us the leaflet attach, how much is it, and then
Yeah.
you show the,
Gradient.
not
I
yet.
think there's good.
Show the color,
I
and then
think
we
it's,
close it on the color.
I think the grasping is good. We have good.
If the gradient goes high, you will
I think
not
it looks
see
good.
the hemodynamic.
Okay, can you show color, and then Dr. Kinney can
Yep.
lock and
Uh,
then close the clip.
Okay.
Tell me when.
Okay.
Okay,
Okay,
this is
you
the first time I'm locking the clip. And now I'm going to close under color.
To see the MR reduction. And you can see, actually, afterwards we can show the V wave. The V wave now is even less, down to 25.
Show the
It's beautiful.
hemo V waves, yes. Actually, I think all the MR is gone.
And you can see also on fluoro how parallel and overlapping the clip arms are.
And look at the V wave going down as we speak.
No, it's perfect.
So with this combination of echo and fluoro, we've been able to really make the procedure more efficient and accurate, because echo is one modality, but fluoro has also another complementary modality to this procedure.
Okay, good.
Yeah.
Let's get are you attached, happy, Gila, with the attachment? Leaflet
Yes.
attachment?
Yeah.
Good. Let's get a gradient.
Yeah. Philip.
Philip, you're happy?
I'm very happy actually. I think this is very good reduction. I think we're going to see the gradient and I think it will be very satisfactory. One thing maybe, Gilbert, you can comment, you measure the length of the leaflet at the beginning of the case. What is the measure you ensure to confirm that you have a good grasp of the leaflet? I think with XTR you have 9 millimeter of potential grasping. And I think your leaflet measures 16, right? So
Wow, gradient is only 1.
Yeah.
Beautiful.
So Gila can certainly measure that for us on the LVOT view. We can do that next.
Yeah, but that's a beautiful result.
Okay, so I think everybody agrees we are ready to release this.
Okay, let me look.
Let's look
Okay.
at the leaflet. I think
Okay,
Philip wants to
okay,
look at
okay.
the
Let me
leaflet
just
insertion in
quickly-
terms of the
quickly look at
length,
Okay.
everything.
the difference in length. So, and Gila, if you can show us the length, that'll be good. What's
Yeah,
the repeat ACT?
I'll get there. Give me
Mark?
1 second.
Mark, what's the repeat ACT? We should be doing every 20 minutes.
I think now that you have reduction of the V wave, you have a very small gradient. The only thing to check is the insertion. So I think you're very good here.
One next to it. Gradient is only one.
We'll see
We can
with
get
the
more
noise.
out. This will be the first case we use 2 XTR in one case.
You want to be the first one.
Yeah.
I'm sure everybody has done it.
No. I think we can do it offline if you
No,
want.
no, no. Offline?
We'll do it offline.
Yeah, offline.
We have a little bit, we have some MR lateral to the clip.
Yeah.
We'll put
Okay, go release that now.
Okay, we are ready to release them.
Did you measure the length,
so
Gila?
focus on this
Yeah,
part.
give me,
Just the difference that I think Philip was mentioning. I think that's an excellent point. You can mathematically subtract and see how much leaflet was actually inserted. With the XTR, I think it's less of an issue because the longer clip arms.
Mm-hmm. I think your grasp was very good. You were at 120. You were high enough in the LA.
Yeah.
That was a beautiful grasp. So I'm not concerned. But I think for the academic purposes, I think if you do that, that's increase the level of your
Yeah.
the reassurance, and then you can release the clip and sleep at night.
Yeah. So the remaining, Gila, you want to comment on the length?
yeah, it's 1.2. I think we started at 1.6, right? That's where we start.
Yeah. So it looks like at least 7 or more than 7 millimeter of insertion based on the leaflet. The pre was 1.8 centimeters. 1.667 meters. So, yeah. So we have
That's good.
five.
So I think we are going to the step of release. So if you see, first thing you'll do is they'll start a flush line. You're going to take out the gripper
I can
line out.
This is this first?
Okay, yeah. First you'll do is make sure your release,
And then
Open
lock,
and then-
unlock, so that we know
and
it
then
is
tighten,
nice.
And then tighten.
Tighten, so it's tight. Good.
Yeah.
Next will be your gripper line. So you take this plastic knob out. Then you have this rubber ring. Take it out. Are you able to see it? Then same. You have this 2 lines. Take out the black cover here. And you floss it. So they're easy movement like that. Yes. They are a little tight many times, but what you can do is move a little bit. See there?
somewhere they're
Good.
entangled.
Yeah. Yeah, it's
Yeah.
good. It's
Yeah.
coming out.
No, 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 no.
No, no, not
Look
coming out
open,
means
yeah.
yes. Now next is your clip. Clip line. Take this out. Same plastic. Then this is a white thread, right?
Just
So
hold
this one you can release it out. Uh-oh. How did this come out like that?
Yeah, we'll cut it.
This is a bad knot.
And, yeah.
So just take it out. Okay, release, unrelease, right?
Neutral, right?
Then leave it neutral. Neutral, neutral, yeah.
No. Yeah.
So you keep rotating towards us till you start
Gila, we're about to
seeing,
release the
yes,
clip.
The cleft.
the ridge,
The
cleft
ridge,
here,
yeah.
yes.
First
Then
floral,
what
yeah.
you do is 8 times,
Floral, yeah.
When you're
Towards
ready to
us,
release,
1,
loosen it.
2, 3, 4, 5, 6, 7,
8.
8. Okay,
so we're ready
Sine.
to release.
Good. Release.
Okay,
Nice.
good.
All right.
And then gripper line up.
Yeah.
Fluoro.
Fluoro. And now when I take the gripper line, always watch the last thing that
This
comes
is very
out.
important, especially some of us who do tricuspid work. The needle can
Can
get very
get
close
stuck.
to the leaflet, so you have to be careful to watch under fluoro, because sometimes the gripper line can be under tension. Okay, Gila, the clip is completely released.
Okay.
Okay.
Take the M knob out.
Yeah, yeah.
So what you have to
Fluoro.
do, undo everything that we did. We had lot of M, undo the
And
M, take
also
out
the
the
plus.
plus. Yes, good.
That's we go good.
So what essentially we did, we
Nice.
had plus, we had M, we undid all of that and pulled the clip delivery system in the guide. So now from here it's very easy. You hold it up and from the left hand I'm pulling it out.
This
Yes.
hand here.
Mm.
Hand on the next one. Next one. Yeah, that's the one.
Keep taking it out
No, see, the other one.
till it
That's
comes.
Next one. Next one.
Yeah, yeah, this one.
No, next one.
No, no, check, no, check.
See the next
You
one.
have to
is
see the
where
panel
you're gonna
first.
close it. This will
Oh,
come
oh,
out
oh,
with
Keep
it.
going,
It's
keep
the
going. No, no,
next one.
keep going, keep going.
Put the whole hand here.
Mhm.
That's it.
Keep going.
Yeah. Now
Good,
all
yeah.
Good.
together.
Yeah.
Once you
And
see
now
the-
everything come out.
Yeah.
You're
Mhm.
holding
Mhm.
flush,
Yeah.
flush, flush.
Mhm.
Good.
That's it.
Okay, flush, please. Just flush too.
And that's it.
Keep flushing, keep
job.
flushing, keep flushing, keep
Okay.
flushing, keep flushing,
Oh,
keep flushing.
good.
Flush, 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 flush. Okay, good. Excellent. Okay, let's look at the
Yeah, we
wave
will.
pressure now. It's
Let's
off
yeah.
there. You want to flush more?
No, I want to flush so there's no
Mhm.
blood at all.
Oh yeah. Mm.
Okay, good. Show me the
I know.
pressure final now. What
But
where
this
are
way
we
to show it
again?
so bad.
Because many times what happens is when you have the
Common
delivery
sense
system,
sometime,
you could have some damped pressure and now
She's
everything
like
is
2
flushed
feet
and
down.
nice and where are we? Oof. Not a lot of
Let's
reduction.
find out from the echo how bad is the MR go. Still you have some V wave.
Yeah.
We have to do another clip.
Yeah, we'll do
Yeah, yeah.
another
We will,
one.
we will.
Huh? Yes, we're gonna be left with this.
But
we
we
can
will
do
still
this one.
reduce by 10 points, like
Yeah.
around 50.
Yeah, we'll
So,
put a second clip.
We are putting a second clip will be where?
Lateral.
Lateral to the
Lateral,
first
right?
one.
Yeah.
Yeah. We have a little bit of medial MR left, but
More is the
we
lateral.
should
More
do lateral.
lateral is more.
Yeah.
And what is the total degree of MR? Earlier it was 4 plus. How much it is now?
It's a good mod.
2 plus.
2.5 plus.
2 plus. No, 2 plus.
Two
Two
plus.
plus.
2 plus.
Good.
2 plus. Moderate.
Okay, so this, yeah, this actually is a nice one to show. This more lateral. You see that? 3D was nice. Okay, is the second clip ready?
Good. So the basically is that in the past, and particularly in the Everest trial, people were happy with this, looking okay, we left moderate and turns out to be that leaving 2 plus MR was associated with the event rate at follow-up. So I think it's, and that's why we are becoming more aggressive now, putting more clips. And so now question is, when you're putting a second clip, are you going to put a XT or NT?
XT.
XTR.
Still
Same
XT.
Yeah. This
I
one is
see.
still by
It's a big
by-
annulus.
and no
Okay.
gradient.
Okay.
So I think
Okay, you want to check another gradient, Gila? Was
Yeah.
one before?
No, no.
It was 2 after, please.
Okay.
I
Ah.
just did.
Okay, 2 is okay.
Yeah.
It's a very important point that anything above 5 you're not going to go
Right.
up. So we are going to introduce the second clip now.
Okay, so
Same-
what we'll do, since they are putting the second clip, meanwhile we can talk about little the theory.
Yes,
Mhm.
Right,
you can.
yeah,
Yeah,
yeah.
yeah.
So second
Because the
clip,
steps are the same. We're
Once
not
you are,
going
yeah,
to
once
repeat.
you are ready to release the clip,
Yes.
we'll interrupt it.
Mm.
Maybe will be done in next 10 minutes anyway.
Yeah.
Okay, now if we can go back to the slides. We just go with the next. Basically, we'll talk about the latest studies of the mitral clip and maybe just one word on the TMVR. Next. So basically, we know the 2 types of MR with the degenerative and the functional. Next. And this is many times differentiation is a little difficult in some of these patients because of the combined etiology. But we have to define them degenerative versus functional because that's where the indication for the mitral clip goes down. Next. So next. So basically primary MR. No medical therapy, although we give some diuretics, which is palliative. Surgery for symptoms or LV dysfunction. Repair is better than replacement. All studies have shown. Recent study from Mount Sinai with the New York State data showed the repair we do more than 95% of cases, and better repair should translate into a better outcome on long term. And then consider prophylactic repair for low risk with long-term survival, particularly patients who have severe regurgitation or have pulmonary hypertension during exercise. Next, for the secondary MR, it's a medical therapy first. Beta blocker, ACE inhibitor, aldactone, diuretics, and then followed by the CRT, and of course surgery only in highly selected patients with CHF. As you know, with the trial done for the ischemic MR, whether you should do the surgical valve replacement or repair versus just do the cabbage on those patients, turns out to be there was no additional benefit. So clearly the surgery remains as a third, fourth, fifth option for patients with a secondary MR, and really only for a class 3 to 4 symptomatic with reasonable surgical risk. Next. So basically Everest trial, MitraClip went through various Everest trial, and of course the high risk, the registry data and so. Next. And basically we all know that showed equivalency in terms of safety, a little better, safer, but efficacy was inferior. MitraClip was inferior to surgery. Next. But more important is at follow-up. As you can see long term, in terms of the New York functional class, very symptomatic improvement in both device group and the surgery group. Only drawback was the severity of MR. 3+ MR was in almost 19-20% of cases, which we know that was one of the issue. Effectiveness was lower. Next, and this is a very important slide with the 5-year data, that after 6-9 months, you see the identical outcome up to 5+ years in the Everest trial. Next. So basically after first 6 months, 9 months is a problem, and after that is all. Now what about for the functional MR? So there are next. So there are multiple the publications. One of them is the 9 studies with the 875 patients, median STS of 12%, showed that by using the clip, your death and hospitalization decreases, because that's important, because that is what we are looking for in these cases, and of course improvement in the overall walking and LV, EF and so, as shown on the left of the screen. Next. So more important is the other is the annuloplasty with the cardio band, and the new device. Next. And actually it has shown also very useful device, just like what we did for the clip. But more importantly, the clip results continues to improve, with being about 65% in case with the Everest trial, now almost 95+%. Next. And tremendous experience worldwide. Next. So more importantly, what I really wanted to talk about, 2 things. One, that what are the data of the TVT registry of the mitral clip, was last year presented by an ACC by Paul Sorja, and then came into the JAC. Next. And basically what they defined is that procedural success was post-procedure MR of less than 2 or below, without surgery or death. And these were about 3,000 patients, but then they have the 30-day and 1-year outcome in about 1867 patients, which is 63%, for death, mitral valve surgery, rehospitalization for heart failure. Next. And this is a key slide, central illustration showing that heart failure, rehospitalization almost 20%, death is 25%, and of course combined is about 40% and so. So I was really taken back. We knew the patients with the TAVI patients and tower patients are sick with the high STS, but even in this our overall mitral clip study, we know it is being done for the high risk or inoperable cases or prohibitive cases, for particularly degenerative, that truly there is a mortality of almost 25% at 1 year. Philip, I was definitely surprised. What is your comment on that?
Well, I think we know that MitraClip is safe, and you know that the procedural success increased with volume and with experience. And I think this data showed that MitraClip is safe, and we can reduce a lot of rehospitalization and sometimes death. So I'm not surprised by that. And we will reduce rehospitalization. The question is about the mortality, and I think the COAP trial will really clarify that.
Yeah, and clearly the reason for 25-26% mortality is because of next. These are the patients who have 82-year mean age, and a median STS risk score was 6.1 for repair and 9.2 for replacement. So really high risk patients. Next. And more importantly, two things we learned. FMR does worse than DMR. You know, FMR was about 18-20% of these cases. Functional mitral regurg where the clip was used, and the DMR did better both for death as well as rehospitalization. Okay, so if they are ready to grasp, let's go back. We can interrupt here. Yes.
Okay, we are going to drop the grippers. Hold on, echo guys.
Show the echo now.
Show the-
Good.
Yeah,
Both
both
echo and
fluoro
fluoro.
and fluoro.
Good.
And my hands. Hold on.
Yeah, no, just close it. Okay, ready?
Hold on. Let it go on live there.
It is good.
Show the third screen. Good.
Oh,
Yeah.
Okay, ready to grasp. Dropping now.
ACT is 309.
Good.
Okay, now
60,
close now.
and do the tension, release
Okay.
tension.
Color.
Yeah, put the color. I release the tension a little bit.
Okay. Okay. You can close.
I can tell you. It's badly shown.
Hmm?
It is badly shown from the side. I don't understand unless
They're
I'm
showing
not
it.
going to
Okay,
start doing this.
I think we're ready to
Color.
close.
I think the position of the,
Okay,
the
we're
second
closing
clip is beautiful
completely
on the
off
angiogram. On the fluoro is very, very close. It's perfect. It's not in contact. It's very good
Yeah.
positioning.
Nice.
Okay, good.
I cannot close anymore.
Yeah.
Okay, yeah. Okay,
This is
good.
very good.
Nice.
The grasp is very.
Yeah.
Okay, now show the full color.
Yep.
Do you see? Who can understand? It should be from the top. You never can understand. What's the point of us doing this?
We'll do it in room.
What's the systemic pressure now? Can you bring it down a little bit? Can you, like yeah, low 70s. Then
Are you completely closed or?
We are completely closed.
Mhm.
Somehow the other thing is since the LA is big, maybe this is all we get reduction of V waves.
Yeah.
Right?
The max. Yeah. Depth dependent.
Yes, nice.
All right.
Okay.
Next step.
Yeah. Back to the slides. You want to
You want to regress? Regress a little more to the side, or you don't think so? Like just.
So we are ready to release?
Yeah, check.
check
Second.
gradient, please?
I'll check.
Check the gradient.
Oh.
Get that empty.
Mm.
It's
Two.
two. Gradient is
Okay,
fine.
good.
No change.
Okay.
So I think Gila, if you're happy, we'll release this. Right? Everybody okay?
Yeah. Is this locked already?
Yeah, this is locked.
No, this is the.
No, this no. This
This
is
no, the clip is not locked.
oh.
The grippers are there. Yeah, the clip was not locked before. Yeah.
Point around my
Okay. So
Okay, so we're going to lock, unlock, right?
yeah, open and then close completely. Flushes are on, right?
Oh, it opened a little bit.
It opened a little bit.
It opened.
Yeah. So close again.
Why
Close
did
tight
it open?
because I think that we didn't lock the clip before.
Mm. I hope it will not open again. Okay.
No, because the clip was not. Yeah.
Now it will open again.
No, it's okay. Now do it again. Because the clip was not locked earlier.
Okay, now it's not opening. See?
Okay.
Yeah.
Now it's good.
And then
Okay,
tight
and now
again.
tight it.
It's a very important demonstration to always check on fluoro in a good angle to see what
Yes.
happened. That was a very good demonstration at
Okay, so we are going to
Gripper lines.
come
Locking
out
of
the
the
gripper
clip.
lines. is closed.
This there? Oh, this there.
Okay, we're taking out the gripper line, same. Too much water, guys. Fountain. Don't need fountain. Same gripper line.
Yep.
Yes, smooth and nice, coming out. Now we'll release the.
Lock
You
line.
guys have locked it
Just
so
hold it,
tight.
yes.
I don't know what's wrong with this new device system. Why it is like that? Okay, take the lock line out completely. Again test,
All
right?
Yeah.
Lock, unlock. So leave it neutral now, this
Mhm.
time.
Mm-hmm.
Okay, ready for the release.
Gila, we're ready to release.
Okay.
We're coming out.
We'll just fluoro in
Okay, right. Yeah. 1, 2, 3, 4, 6, 7, 8. Yes, ready, coming out. Yes. Okay, now
Okay.
same. Stay on fluoro and we'll take the gripper line out. Watch it. Nothing happens to the tip of the needle and the gripper is out.
Okay, the clips are completely
Right.
released.
Yep.
Okay. Floral, please, I need to put this in a
So
sec.
undo the M, undo the plus. Nice. M came out slowly and just take out the clip
Okay.
delivery system into the guide.
Mhm.
So we'll do our final measurement of the. We're going to give some flush. Everything will come out, right?
Mhm.
Okay, good.
What is the blood pressure at this point?
The blood pressure is now mean of 80, 133/47.
Mhm.
So I'm going to flush. Take it out.
Okay. So the blood pressure did come up after
Blood pressure
afterwards.
came up.
After the clip. Yeah.
Okay, good.
Hmm?
Flush. Give me some more flush.
So Gila, how do we look now?
D- mm, we have some
Is that the
residual
pressure
MR.
recording?
We will. 1 second. I'm just flushing, making sure everything is good, clean.
Liz.
Okay. Show me the.
Yeah, so 50 to 35.
What's the blood pressure now?
Mean of 80. 62, yeah. Very dynamic. So
Very good.
yeah.
That's good. Nice reduction now. Wait for everything come down.
Yeah.
He is below 25.
Oh,
Okay.
I'm gonna look. Yeah, look for it.
So this is the final V wave. You see the V waves, just about.
35.
I
Okay.
can say what 20, between about 20, right?
Let me.
Did you give some?
Significant
Sorry,
reduction, yeah.
Because they're freaking out. You know. Don't worry,
Okay.
Marcus.
Okay,
What's the
Gila
next
shows
step?
the
It's
final,
us, it's
nothing.
us,
The
it's
Show the
us.
echo.
guide shows echo. Now the guide catheter will come out.
Yeah.
When the guide come out.
Yeah. Okay, we'll just pull the whole system back. So we're gonna pull the whole system back. You can see on fluoro.
I don't see an effusion.
Okay, so let's show us the septum first.
Yeah, come on.
Okay. So now
It's
we're
out.
back in the right atrium.
Wow.
But show the MR. Have you shown final MR?
Shows the final MR readout. She's going to show
Yeah.
a little bit of the
ASD?
ASD. Nothing. No flow.
Wow.
That's just a central jet of 1+ now.
Blood pressure.
Good?
Looking good. Okay. We are done here. You can finish your slides.
Yeah.
Yeah, beautiful. No, but this is definitely what is threshold of we actually have systematically not analyzed, but last year roughly when we saw it's about 18% cases we did a second clip, and I think only a handful of cases, 3%, 2% we did the 3 clips. And what is your experience at your center, Philip?
Yeah, very similar. I would say 20%, 30% of the case we put a second clip. Sometimes we did case with we put 3 clips. I'm very impressed that you did 2 clips in almost less than an hour. So that speaks to the beauty of the procedure.
Because we have to teach step by step.
Yeah.
Otherwise, about 40
Even
minutes.
okay,
less
let's
than
go
that.
back to quickly. I finished mine in next 5 minutes. But most important is we are talking about, now go to previous slide so that we get our rhythm back. And that is the data of the TVT registry showing that the functional regurgitation has 1.5 times higher mortality and almost twice rehospitalization compared to patients where we did the clip after the DMR. Next. So key is very important. The way that what we leave residual, and this was the beautiful illustration of it, that you leave a 2+, more than 2+ mitral regurg. You see, your mortality at 1 year is almost 50%. So clearly you want to bring it to 1 to 2%. Next. Also we learned the TR. In this patient, baseline TR was only mild, but baseline TR is a very important predictor of outcome of the mitral clip. You can see once you have severe TR, of course sometime may or may not change after the clip, but almost has 40% mortality. Next. And then these are the 5 independent predictors which came: age, patients on dialysis, and of course the COPD which we know. And then very important is the patient with the tricuspid regurgitation and leaving more than moderate mitral regurg, means 3 or 4+ mitral regurg for endpoint of death, and similar endpoint death for the death and heart failure rehospitalization. Next. So clearly we understood what the problem. Second is, which is evolving, and I'll ask my colleagues both Anu and Gilbert to talk about that, how we are using it in our routine practice, is to see this mitral valve pressure gradient. We know residual MR is bad, but what if in order to decrease the MR you create the stenosis? Next, this is the data from Germany, and they basically saw that both hemodynamic as well as the echocardiographic good correlation. So that's a fantastic that you don't have to do the hemodynamics in every case, because echo gives you a very good idea. Next. And showed that based on which we knew always that the various events occur in these patients, 200+ patients, 25 were both functional as well as degenerative regurgitation, and degree of MR was associated with a bad outcome, 4+, almost everybody died within 2-3 months. The next important point was next slide, and that is that if your gradient was less than 5 or more than 5 on the hemodynamics, or on echo, less than 4.4 or more than 4.4, there is a clear-cut dichotomy in terms of subsequent outcome. So clearly is that you want to, of course, decrease the MR, but not at the expense of the stenosis, causing mitral stenosis. And this is what we have had a rare cases where they wanted to put a clip, but after the clip, the gradient became 6 or 8, and then of course they did not release the clip. So I'll ask just the comment on both with Gilbert and Anu that how many cases which we have, we wanted to do mitral clip, you had a good grasp, but there was a more than 5-6 millimeter gradient, and then you did not release the clip.
For the first clip, I would say in all these cases, we have done 2 cases, we have come out where we did not release it. But for the second, maybe again same, I would say a handful, maybe 4 or 5 cases where we did not release and we came out.
Yeah.
And I think for the second clip, we are saying 7. For the first clip, as long as we know we are 5, anything more than 5, we would not go with the second clip. We'll know if you are 5 already with the first clip and you do second, will be 7 or more.
Yeah.
So you didn't want to get into that. That's a rule we have had here.
Yeah, the 2 points. I think one is that the continuous hemodynamic really helped us, especially when there's no dampening. We actually customize our patient on the gradient. I know the paper said 5 and 4.4, but we've been patients where actually we had 6, gradient 6, but the V wave stayed down, the airway pressure stayed down, so we did not feel that the patient had functional stenosis, so we deployed the clip. The other point is that depends on the pathology. Barlow's valve with a lot of excess leaflet tissue is difficult because a lot of tissue, so the gradient can go up much more quickly, or they have small valve or mitral annular calcification.
There are
Good.
cases, see, one good thing that since we are doing this hemodynamic measurement, right? We know we put a first clip, it went down by 10 points, 12 points. And when we are doing a second clip and you're questionable, right? Your echo gradient is 6, second clip 6, and then but your V waves shot up again. We know that, releasing
have
the second clip, we will have a issue
problem.
there.
Yeah, so that's
why
stenosis.
this LA pressure monitoring has been very helpful. We are not talking about invasive arterial measurement where you put a catheter in the LV and check the gradient. We are not doing that. We just go with the echo gradient.
Yes.
But I think LA is a very easy. We are not doing any extra LA catheter, which in the beginning that was a teaching that you put an extra pigtail in the LA and then you keep doing your clip with the second transseptal.
No, actually, these guys from Germany, they did.
Right.
Oh.
They're from the same sheath. They put a 4 French pigtail into
Right.
the
Not
left
same
atrium.
sheet, not that.
Yeah.
No, they did from the same.
Okay.
The
Yeah.
same, put a wire and then just put a 4 French.
4 French,
And
yeah.
then they put a 5 or 6 French with the left radial into the ventricle. So they did a very, very intense
Right.
and guarded hemodynamic monitoring. And later on the conclusion in the discussion, they did say that we should not be doing, because echocardiographic, the biggest reason what they did, abandoning the hemodynamic invasive, was echocardiography has a very excellent correlation. Next, and this is where the important slide. That is MR grade, or you have the gradient. As you can see here, clearly with the MR grade, you have a bad outcome of the death and mitral valve replacement, and of course the gradient of 5 or more than 5. And what really makes it is the particularly if you have a more than 5 gradient and you have a more than 1 plus MR, you look at the event rate of 52% death rate. Tremendous. So the key is this double combination is worse than anything single by itself. Next. And so these are the 2 important points. Next. And then key was the multivariate predictors, of course high BNP, and then the gradient of more than 5 or MR gradient more than 2 plus. They also found that if your gradient was more than 5 and but your MR was less than 2, was still in the bad side. So the key is that we have therapies to treat the regurgitation. We don't have much therapies to treat the mitral stenosis medically. So therefore, this invasive monitoring should be the part and parcel of your technique, because that is where you are going to make a patient better. You cannot exchange MR for MS, because MS will be even tougher to treat than regurgitation. Next. So this basically is the conclusion. Next. I think we just come.
Yes.
So we know that FDA approved it, and it's a 2B guideline mitral clip at this time of the ACCHA, patient with the primary MR and severe symptoms. Next. The co-op trial, which has been completed, and of course will be presented in TCT this year. Next, and this one basically was the primary endpoint. Next slide. That patients who have high STS risk of 8 or inoperable, and the primary effectiveness is the 1-year follow-up of all patients. Recurrent heart failure hospitalization is the primary endpoint, and primary safety endpoint is of course composite of death, stroke, and worsening kidney function, LVAD, or cardiac transplant. Next. I mentioned briefly earlier, there is another device which is similar to what we do here, the cardio band. Next. And initial data looks very nice. Multiple the clips are placed to really decrease the mitral annulus cinching. Next. And the data have been very good. Next. But again, a small number of patients and good symptomatic improvement for these cases. Next. And just quickly, next. The mitral valve treatment. Next one, TMVR, basically many devices. Next, one of them which we are actually part of it is the Medtronic 12 Intrepid. Next, and Apollo trial, which are part of both roll-in as well as the randomization. We have done now total, Gilbert, how many cases?
3.
We've done 3 so far.
3,
Yeah.
and they're all roll-in yet, right? But
That's
this
correct.
is the first trial of the randomized patients into high risk, which will be randomized to surgery versus the TMVR, and really we need to see. But very nice
Apical.
device. The transapical, very nice device. Really eliminates the regurgitation completely. There is no stenosis, and terrific. It just it's still some complex steps, but works very well. Next.
Nice.
And last, so I put it together. So that is the evidence-based therapy for MR. Degenerative, we know, low risk surgical MVR. If you're functional, maybe surgical MVR in some cases. But if high risk, still surgical MVR or commercially mitral clip registry. And then, of course, high risk functional is the MitraClip, as we do as a registry or co-opt and reshape trial, which are two done, and hopefully year end will tell us that this field is going to explode or implode. And I don't know what is your guess, Felipe?
Explode.
I think this field will explode probably with multiple winner, multiple device. It's a very complex problem that probably deserves 4 or 5 options. And I think you really demonstrate very well here. So you can try MitraClip, and if it doesn't work, you can go to the second line treatment, etc., etc. So I think we are very early in the game of TMVR, but I'm sure that this field will explode, and with multiple tools in our toolbox, I'm pretty sure in 10 years we will be able to conquer this problem.
And hopefully we'll be able to have this co-op positive on our side, so we get approval for functional, because that's a bigger group. That's actually, in my opinion, 5 times the group of our non-operable degenerative MR. Next. So lastly, next, basically I put it together that MitraClip therapy is FDA approved for degenerative MR in high-risk patients, and patients with a symptomatic functional mitral regurg in high surgical risk. Co-op trial has been done. We're waiting for the data. And then finally, important points are MitraClip implantation of the TVT registry and other studies in high-risk DMR and FFR have shown acceptable acute results with more than 92% success, low in-hospital mortality of 2 to 3%, but long-term mortality continues to occur, largely dependent on baseline comorbid conditions and residual MR post-procedure. Next, we quickly go through the questions which we do, and this actually will be later on the CME event once all things are acquired. The following is the true statement regarding outcome of MitraClip in the Everest trial. MitraClip had higher complication than surgery. MitraClip is superior to surgery in effectiveness. Majority of the MitraClip patients had severe residual MR, and MitraClip was equal to surgery after first 6-9 months in terms of mortality and future events up to 5 years. Next, clearly the answer is D. Next, question number 2. Following are the primary effectiveness endpoints at 1 year of the co-op trial for functional mitral regurg: mortality, rehospitalization, CVA or MI. Primary endpoint, it was B, rehospitalization. Next, question number 3. TVT registry data for MitraClip procedure showed the following, except overall success of more than 92, in-hospital mortality of less than 3, 1 year mortality of 25 to 30%, 1 year repeat heart failure hospitalization of 50 to 60%, and higher mortality in FMR versus DMR patients at 1 year. Next, clearly we know that the repeat hospitalization was about 20% in the CLIP patients. Next, following are the independent variables of mortality at 1 year in the TVT registry of MitraClip, except female sex, residual MR, severity of TR, and age. As you said, the female sex did not. As you know, in the many of the TVT, in the tower registry have shown female to have a better outcome compared to male, but clearly there is no difference, sex difference so far, at least in the TVT registry. Next, the last question, which is, what is the cutoff for the residual mitral valve pressure gradient on hemodynamics, which is independently associated with poor long-term outcomes? We have spoken about 2, 4, 5, or more than 5. Next, and clearly it is 5. With that note, they want to show what
They
they
closed it.
okay.
Okay, Asad, anything you have to say?
This is pretty good. Like
Show just the final steps there.
we close the per-close suture pretty similar to how you close the
Good.
TAVR, except you're a bit slower because there is no muscular tissue, so it oozes a bit afterwards as well. And then we have done the per-closes, and now we have just cinched our
Anatomically very nice.
figure of 8 suture, which we'll take out tomorrow morning. It's okay. It will just keep some subcutaneous pressure just to be on the safe side. Otherwise, it's pretty good.
And heparin, we just leave it. There is no need to reverse or anything else.
Nothing.
We don't
We
need
don't.
to, yeah.
It was, I know it was started 270, second one was 309. So nurses are very good. Every 25 minutes, 20 to 30 minutes, right? At 30 minutes, we keep checking ACT, and anesthesia will replenish heparin as we need it to keep it about 270.
Okay, so with that note, we completed our today's webcast, and Philip, you just make your concluding comments.
Well, thank you for the great work. So I want to thank the heart team member of the Cath Lab, and thank you for joining us for these exciting cases, no doubt. The recording of this case will be archived on the website www.ccclivecases.org later today. We will also send an email out in the next couple of weeks when this case is available for CME credit online. Structural Heart Live cases occurs every other month on Tuesday at 9 a.m. And the next will be on Tuesday, September 11 at 9 a.m. Once again, thank you for joining us and congratulations to the team for a great case.